For our second lecture, we'll be taking a look at rheumatic disease. So rheumatic disease involves inflammation of the joints, ligaments, or muscles, which results in pain, limitation of movement, structural degeneration of a single or multiple parts of the musculoskeletal system. And so what we'll see is, it's believed that many of these diseases have an autoimmune component. But again, what we're looking for is no specific identifiable cause. And then also what we're looking at is there is really no true cure, which again, when we say cure, we're looking at, I can't just give you the pill and then you never have any more problems after the fact. So we do have treatment options, and some of them are very high quality with really good outcomes. But again, it's not like a bacterial infection where I give you the pill, the bacteria is gone, and it's fixed. So these are chronic in nature, and treatment typically includes a combination of medication, occupational therapy, physical therapy, and medical nutrition therapy. So the diseases that we're going to discuss, so let's just talk a little bit about them. So we're going to talk about osteoarthritis, which affects 27 million Americans, which is a little bit less than 10% of the population. Gout, which affects 3 million Americans. Fibromyalgia, approximately affects 5 million Americans. Rheumatoid arthritis at 1.5 million. Sjogren's at somewhere between 1 to 4 million. So again, we'll talk about looking at if people can identify their symptoms, if they're getting treated, depending on the severity. And you probably have heard of lupus before, but again, so it's usually called lupus in shorthand, but the actual disease is systemic lupus erythematosus, or SLE. And so this affects somewhere between 161 to 322,000. So arthritis, going back to our medical terminology, so we know that itis is inflammation, and we know that arthro, we're looking at joints, so this is inflammation of the joints. And so the risk for rheumatic disease increases with age. So specifically when we talk about osteoarthritis, right, typically associated with the elderly, but there are other risk factors. So repetitive joint injury. So for example, if you have torn your ACL multiple times as an athlete, you're at very high risk for developing early onset arthritis. Inherited cartilaginous weakness, right? So if you have a genetic susceptibility, so you have a history of family members that have bad cartilage, you have family members that have a history of bad arthritis, family history, gender, and environmental or exposure factors. So again, with arthritic conditions, so these are diseases and conditions affecting joints, tissues surrounding joints, and connective tissues. So we're going to talk about, specifically osteoarthritis, rheumatoid arthritis, and gout. And so this is the leading cause of disability in the United States. And so again, I think, sometimes there's this perception that it's just achy joints, oh, it's uncomfortable. And I don't think sometimes people realize that this can be life-altering, right, with severe limitations and severe pain, right? So affects 50% of those over the age of 65, but it can affect all ages. So again, not just in the elderly, that is most of the cases. But again, we looked at with those risk factors, multiple causes, right, triggers, etc. So risk factors that are modifiable, so being overweight, so of course you can manipulate your weight, so that's modifiable. Joint injuries, now you can't do anything after the fact, but you can if you are playing a sport, right, using proper protection, or then, right, if you continue to play a sport or to stop doing a sport, right, those are choices that you make. So for example, with kids, right, when they're learning to rollerblade, we have wrist guards, but you'll never see any professional, right, skateboarder wearing wrist guards. But again, a joint injury at that age sets you up for lifelong problems versus, right, as an adult, you're probably a little bit more aware, better body control, etc. But again, if you've torn your ACL and you continue to play football, etc., and you tear it a second time, right, again, those are choices. Now, again, I know depending on how they say choice, but, it's kind of like when they tell the doctor and you go, well, it hurts when I do this, and they say, stop doing that. And so infections, so we'll talk about, for example, untreated salmonella infections can actually damage the cartilage in the joints. So again, you need to get proper medical treatment, etc. But this is just one example, but there are other infections that can put your body at risk. So risk factors that are non-modifiable, so things you can't do anything about. So the female sex at 60% of cases, and age, again, as of now, right, there's no way to reverse aging. So again, your risk increases with age, and again, you can't pick your family, right? You're stuck with them right now as you're listening to this. So family history, right, is a non-modifiable risk factor. So inflammation, so defined as an innate, non-specific response to a cellular injury. And so what we're talking about is that so the stress response, right, and inflammation is non-specific, which is any type of physiological stress on the body induces this response. So this can be from an infection, chemical exposure, allergens, physical trauma. And so what you'll see is, so the inflammation response is going to start off localized. And so this is your classic swelling, your redness, right? The injury gets hot to the touch, it gets swollen, but it can also have a systemic response. So the localized response, right, is supposed to last, right? It happens seconds after the injury. It's supposed to last for several hours, and then it should subside depending on the extent or the severity. But you can have chronic, constant, low-grade inflammation, which is a systemic response. And again, that's that we were taking a look previously looking at labs, right? And so we were looking at CRP, albumin, etc., right? You can have chronic elevated CRP, which is that chronic marker of inflammation. And so here you can actually see, so that response. So here again, we have this injury. So someone's gotten a splinter with bacteria introduced. So here we have the release of histamine, or a histamine response from the mast cells. So this increases vasodilation and capillary permeability, which is a big fancy word for saying the blood vessels get bigger, right? The capillaries loosen up, and so what you have is a bunch of fluid floods the site, and you get swelling, right? So this is why you have that. It's kind of tender to the touch, and it's painful and swollen. So you have a local accumulation of fluid. Again, this should then increase, right, your immune response, right, an increase in white blood cells to fight off that bacteria, and it's going to flood the site, and you should hopefully mount a defense. Now, if for some reason this was some overwhelming bacteria that you couldn't fight off, you could long-term develop a systemic response. So the stages, so the first is what we have is the vasomotor response with vasoconstriction. So this decreases the diameter of the blood vessel, which reduces the amount of blood to the area, which should then hopefully stop you from bleeding. So if it's trauma, you won't bleed too much. Then we have vasodilation, though, which is the reverse, where we have an increase in the diameter of the blood vessel. Now what this results in is hyperemia. So remember that emia is of the blood, or in the blood, and so we have too much of the blood. And so what this is this is increased blood flow to the site of the injury. And so this results in redness, heat, swelling, pain, and sometimes altered function, which is so things can be swollen so much that they're stiff, or you're unable to, for example, bend your fingers or your elbow, right, if the injury is severe enough. This provides additional oxygen and nutrients through the blood, increases the transport cells for healing and repair, and again, so pain caused by the increased blood flow will limit movement, which again should serve as protection from further injury. So again, what we do naturally is known as guarding, which is when you have that injury, it's going to hurt, it's going to swell up, right? You're going to hug it close to your body and say, I don't want to move it. Well, that's your body's natural reaction trying to protect you from further injuring the site. Now we've talked a little bit about this, so we've talked previously about leukotrienes, and so similar to that concept, right, we're going to talk about in that family is eicosanoids. And so these are derived from our polyunsaturated fatty acids. And so we have our prostaglandins, which regulate the contraction and relaxation of smooth muscle tissue, and thromboxanes, which are vasoconstrictors, which facilitate platelet aggregation. And again, we've previously talked about leukotrienes. So again, we're now moving into expanding that concept. So prostaglandins and thromboxanes are formed by cyclooxygenase, or the COX system, and are known as prostanoids, whereas leukotrienes are the product of lipooxygenase. And so diets enriched with PUFAs enhance the synthesis of anti-inflammatory prostanoids and are desirable for the long-term management of rheumatic disease. So it's a big fancy word of saying, which is arthritis is inflammation of the joints. We want to continue, right, that consumption of those fatty acids that reduce inflammation, and not that unbalanced intake of fatty acids that increase inflammation. So the signs and symptoms of inflammation, so again, redness, warmth, swelling, and pain. And so systemic signs are going to be fatigue, malaise, and fever. With lab markers, so we have our acute phase proteins, so these increase more than 25% during inflammation. This again goes back all the way to MNT1, with increase in white blood cell count, increase in CRP, increase in fibrinogen, and increased rheumatic factor. And so our management for this inflammation, and again, we're going to be talking about the short term, and so these can be used long term, but again, we have to be aware of some things. So this is the classic, right? Applying cold to an injury to reduce swelling, so it induces vasoconstriction. Pressure and elevation, right, will decrease blood flow or that hyperemia. And then from a pharmacological standpoint, so we're looking at a family of medications, which is NSAIDs, that non-steroidal anti-inflammatories. So these inhibit prostaglandin production by inhibiting the COX-1. So we were talking about, right, looking at those eicosanoids and looking at that inflammation and the COX system. And so this stops that, i.e. it stops the inflammation. And so you're pretty familiar with COX-1s. These are going to be things like your Advil, your aspirin, etc. And then you're probably also familiar with your COX-2 inhibitors. And this is basically the next class up. So basically you have Advil is going to be your COX-1, and then Celebrex is your Advil on steroids. That's your COX-2 inhibitor. Now then we also have, right, so things that are steroids, and these are corticosteroids like prednisone, cortisone, and Medrol, which are used again. So these are steroids, but they're going to do the same thing, which is to help manage inflammation. So unconfirmed therapies for inflammation. So willow bark and ginger, again, may relieve pain. So in essence, what you're doing is you're getting low doses of aspirin. So willow bark is how we actually isolate aspirin, or we did in the original formulation. Now we do it synthetically because it's much cheaper. But so chronic intake of those plants may help with inflammation. Valerian root, feverfew, boswellia, and curcumin, again, were being looked at as possible treatments for rheumatoid arthritis, so in essence for severe cases. And other things that may help, so meditation, tai chi, relaxation techniques, thermotherapy, which is a fancy word of saying a heating pad, and spiritual practice may help reduce pain. So again, you're really looking at symptom management though. These aren't things that are going to actually remove the cause of the inflammation. They're just going to help with the symptoms. So the first disease we're going to talk about specifically is osteoarthritis. So chronic joint disease involving a loss of habitually weight-bearing articular cartilage. So this is the most common arthritic condition and leading cause of physical disability, increased healthcare costs, and impaired quality of life. Now you may see some old-timey docs will put it in their past medical histories as degenerative joint disease. So this is characterized by a loss of load-bearing articular cartilage and cartilaginous destruction, leading to inflammation of the tissues, joint pain, stiffness, limited movement, instability, and deformity, and the development of bony outgrowths known as osteophytes. So, when you think of a little old lady and they say they have arthritis, so if anybody's ever seen Happy Gilmore and she's like, my hands hurt, and they've been, doing something like a delicate movement like quilting for hours and hours, or you're very, very stiff, or you have pain, it's usually, not always, but usually osteoarthritis. And so here we can see a photo of a healthy joint on the left. And so you have the cartilage. And so in essence, cartilage is very similar to, if you can imagine, a non-stick frying pan. And so the cartilage is the non-stick coating. And so what happens is it allows the joint to slide without resistance or pain or friction. And with osteoarthritis, something has caused basically someone to scratch or scrape off the non-stick coating. Well, now things start to stick and build up and rust, etc. Or in this case, because of the rubbing and the damage, it starts to build up bone spurs, right? You have small amounts of bone building up at the end of the joints. And so remember, the stimulus for the bone cells, right, is injury. So if your bones rub together and get injured, your body doesn't realize why that's happening. So it has the same standardized response, which is it's going to then grow additional bone, except for these are bone spurs, and that's bad. And so here you can see, so osteophytes is the fancy word for bone spurs, so you can see in the photo on the right. So in addition to, right, so the actual damage to the surface, so when the bones do touch, so the infamous quote-unquote bone on bone as the cartilage wears away, but the bone spurs actually then damage the soft tissue nearby, which causes that inflammation and pain. Now we said, right, this is load-bearing articular cartilage, so these are joints that move around or bear a heavy load. And so you can see we have the cervical spine, the lumbar spine, the knees, the hands, the hips, and the feet. So for example, not many people get arthritis in their elbows. Now I probably will, honestly, because my elbow has been dislocated multiple times from practicing jiu-jitsu. But you'll see that, so in essence, your shoulders, right? Unless you've had a shoulder injury, right? You've had a labral tear, and you've had your shoulder repaired multiple times, then you're probably in for some arthritis. But the big one, so for example, in modern times, we're very concerned about the cervical spine. So depending on if you're watching this or listening to this on your phone versus on your computer, if you are looking down at your phone, right, that's one of our major concerns, that we're afraid that people will develop cervical arthritis basically in their spine because of looking down at their phone so much. So we'll see. But basically, right, that posture of being slouched in the chair looking down at your phone, very, very bad long term for your bone health in your spine. So major risk factors for osteoarthritis. So we've got age, female sex, family history, trauma to the joint or soft tissue. Again, don't get me wrong, I love playing jiu-jitsu, but you play stupid games, you win stupid prizes. Repetitive joint stress related to occupation. So for any of you who have worked in food service, you will notice that in front of all the prep tables there are rubber mats. Or if you've ever worked in what's the word? Service industry as a cashier. Ooh, that took too long. If you've ever worked as a cashier, you'll notice that they have a mat underneath them. And so standing on a concrete surface for long periods of time will give you early onset arthritis in the hips, knees, and feet, which is why they were required to provide you with that mat according to OSHA regulations. Now, obesity also increases our risk for osteoarthritis. But we do see, so just a 5-kilogram weight loss can decrease symptomatic or risk of symptomatic knee arthritis by 50%. So you're looking at a 12-pound weight loss that has significant health benefits. So our treatment goals for osteoarthritis. So we want to reduce joint inflammation and pain, maintain mobility, and minimize disability. And so the way we can do this, and so again, this is we meaning the medical community, not just dietitians, is improving body posture, wearing proper footwear. So for example, don't get me wrong, they're really cool, but we shouldn't actually be playing basketball in Chuck Taylors these days, right? There's much better padding for your feet. Now they're just more worn for style. Weight loss and achieving an improved body weight, but we'd like to get you to ideal, but realizing that's not always possible. Periodic resting of the joint. So you'll notice that, for example, if you worked in the service industry, is that there are mandatory breaks. Again, thank you, another OSHA regulation. So you have to take a break. You can't be standing on your feet nonstop. Application of heat. So again, this is your classic heating pad or thermotherapy. Physical activity as tolerated, which seems counterintuitive. But what actually happens is that there's an increase in synovial fluid during physical activity, which is in essence, so we have the nonstick pan, and it's been damaged, but when we exercise, it's like pouring oil into the pan. It doesn't fix the pan, but it helps us get a little bit more life out of it. You continue to cook and still use the pan without it becoming totally useless. So that's in essence how synovial fluid and physical activity work in arthritis. Therapeutic exercises, so again, we can help strengthen things or reduce symptoms. So for a while there, I had what's known as patellar tracking disorder, which is my kneecap would slide around incorrectly. And so what we did is we actually had to do some exercises to strengthen the muscle in my knee to then have it track correctly so it would stop rubbing in the wrong area. So again, certain exercises, depending on how early they're adjusted or caught, can improve symptoms and prevent osteoarthritis, and NSAIDs for pain management. Now, if that doesn't work, we do have some other options, so less conservative options. I'm sure if you've ever watched any kind or heard of any kind of sports, you've heard of arthroscopic debridement, which is a fancy word. So what you'll often hear is that athletes will say is that I got my knee scoped. And so what happens is if you go back to the previous photos when you actually looked at the injured knee, you saw there were rough surfaces, you saw there were chunks floating about of damaged cartilage, and in essence, an arthroscopic debridement, or having your knee scoped, is they go in, they vacuum out all the junk, they take the Dremel tool and those bone spurs and that rough spots, they just kind of bzzz, and they smooth everything out. So again, once the coating is gone, you can't put the coating back on the pan, but I can scrape off the rust, I can scrape off the rough edges and keep everything nice and smooth. But again, this doesn't actually fix the issue, so you'll see that athletes will often, once you've started getting scoped, they're actually going to get it scoped fairly often. It's basically you have to keep removing damage from the damaged tissue from the joint. Now the fancy word is a total joint arthroplasty, which is a fancy way of saying joint replacement. So we have a total knee arthroplasty and a total hip arthroplasty, which is a complete removal and replacement of the knee. And then what we say is the hip, it's actually the femoral neck, is actually the upper part of the thigh. So an osteotomy, so part of the bone is removed near the damaged cartilage or joint, allowing weight to be shifted to where there is still healthy cartilage. So this is kind of buying you time and is a more conservative surgery. Now, we have total, so we have, in essence, in order of severity, we have getting your knee scoped, an osteotomy, which is just kind of removing part of the bone, and then a full replacement. And we're actually really good at surgical reconstruction now, but that's not an excuse to just, oh, well, you know what, I'm just going to not take care of my joints now, and I'll just get the replacement at 60. That's not how this works. Right, we need to have good nutrition, a healthy body weight, right, exercise, and take care of our joints. There can be severe complications, but in the grand scheme of things, so if you have a knee replacement, you'll have the surgery in the morning, you'll wake up, they'll have already started physical therapy on your knee while you're asleep, you just won't know it. It's what's known as a passive motion device. It actually bends your knee back and forth while you're asleep. You'll be walking on that knee later that day, which is pretty wild. So looking at a medical nutrition therapy for osteoarthritis, so there are anti-inflammatory diets. It's very similar to the Mediterranean diet. Again, a focus on fruits and vegetables, less processed foods or fast food. Again, so antioxidants in a supplemental form, though, are not shown to be beneficial. So again, it's more of a lifelong adherence and a chronic intake of antioxidants from fruits and vegetables. Maintaining and making sure that vitamin D and calcium intake meet the DRIs. And so capsaicinoids, or capsicum cream, is one of the actual few topicals that's been studied. It's been shown to reduce osteoarthritis pain, so it actually does work. If you're like debating between Bengay or the capsicum, so it actually does work. We're also exploring S-adenosyl methionine, or SAMe, again, which shows promise for pain reduction and improved mobility, and glucosamine and chondroitin. So again, preliminary findings show reduction in moderate to severe pain, but not in mild. So the good news, though, is that glucosamine and chondroitin are very cheap, but they're not going to do a whole lot for mild pain. But if it's bad enough, they're going to do something, and something's better than nothing, as long as you're not allergic to shellfish, which is they are isolated from shellfish. So they will trigger gout or a food allergy, but otherwise, they're very safe and very cheap. All right, so we'll move into and talk a little bit more about rheumatoid arthritis. And so just to understand that, with the exception of the fact that they both have the word arthritis in them, so osteoarthritis and rheumatoid arthritis, these are not the same thing. They could not be more different. Please realize these are extremely different diseases. They just happen to both have joint inflammation as a symptom. So rheumatoid arthritis, so a chronic inflammatory disease in which the synovial membrane of the joint becomes inflamed, resulting in swelling, stiffness, pain, limited range of motion, joint deformity, and disability. So this is an autoimmune disease, and so it's characterized by periods of it gets worse, it gets better, gets worse, gets better. And again, so we know the mechanism, but what triggers the mechanism, the exact cause, is unknown. Now, it is believed, right, there is a genetic susceptibility and then an exposure that plays a role. But thank goodness, right, it is less common as it is much more severe than osteoarthritis. So again, with the exception of the fact that they both have arthritis in the name, realize we're talking about very different diseases. So the clinical manifestations, so initially patients will present with poor appetite, weight loss, fatigue, and generalized weakness. And then what we're going to see is so inflammation of the joints in the hands, wrists, knees, and feet. So resulting in warmth, redness, swelling, stiffness, and pain. And so this is caused by an accumulation of synovial fluid. And so inflammation results in the thickening of the synovial membrane, known as pannus. So enzymes from pannus digest adjacent bone and cartilage, causing deformity, pain, and immobility of the joint. So previously we saw, right, a loss of cartilage, and so then we saw, right, those bone spurs. But here we're actually seeing much more significant damage and deformity. So again, because we're having enzymatic digestion, right, of the bone as well as the cartilage. So here we can see, right, on the left, similar to the previous photos, a healthy joint, and on the right, so we can then see, right, so the actual membrane itself, where we're seeing not only damage to the cartilage, but then also eating at the underlying bone. Again, another photo where we can see that there's going to be inflammation, and on the right, so we can see inflammation of the joint capsule, and then long-term, right, so you can see in the purplish, right, the actual digestion or damage of the tissue to both the cartilage and the bone. And so again, when we think of arthritis, right, we're probably normally thinking of aches and pains. Oh, it's just, you're gonna have to warm up more. It's just kind of sore. It kind of hurts. If I take some Tylenol, it'll get better. And again, I don't think people realize that osteoarthritis is bad enough, and rheumatoid arthritis, right, is on an entire other level, right? So you're looking at significant joint deformity and damage. And again, with the exception of arthroplasty or joint replacement, right, this damage is essentially irreversible, right? So again, you're looking at an extremely painful condition that impacts, right, our patient's abilities to prepare meals, go shopping, etc. So our treatment goals are to reduce pain and inflammation, protect the joint, maintain function for as long as possible, and, right, prevent or control any systemic infections. And so again, the patients are going to be, because this is an autoimmune disease, the patients are going to be on immunosuppressants. But again, that means we have to monitor and keep a lookout for any other systemic infections. So this can also include, though, treatments, things like physical therapy, NSAIDs, salicylates like aspirin. The problem is, right, is that long-term intake of both NSAIDs and salicylates, right, can be damaging to the GI tract. Again, we're looking at immunosuppressants and glucocorticoids. And so again, taking into account, so for example, things like food poisoning right now become a much higher risk, right, because we've decreased the immune response along with things like secondary illnesses. And so the other class of medications that the patient may also be on is disease-modifying anti-rheumatic drugs. And the most famous of this is methotrexate. So you may know methotrexate because it's also used as a treatment option in chemotherapy. Right? It's a very important drug, but it does carry with it some significant side effects. So surgical treatments may include synovectomy, so actually removing the synovial membrane, joint replacement or tendon reconstruction depending on the severity of the damage. Again, with exercise, physical therapy, and occupational therapy, right? And so our concern, so it's what's known as rheumatoid cachexia. So this is a loss of body cell mass that can lead to muscle weakness and loss of function in those with rheumatoid arthritis. And so in essence, you have this long-term chronic inflammatory condition that's actually going to cause this wasting away, this decrease in muscle size, this weakening of the muscles. And so in essence, they're kind of wasting away from this other illness. So as we discussed previously, so articular damage may limit the ability to perform nutrition-related ADLs, including shopping, cooking, eating, right? So looking at self-feeding, right? The ability to hold utensils. So involvement of the temporomandibular joint may affect the ability to chew or swallow. So again, again, it's one thing we think of arthritis affecting the hands, we think of it kind of affecting like the knees, the feet, etc. But right, if also it affects your jaw, that it could impair the ability to eat. So the progression of rheumatoid arthritis may cause excessive protein catabolism and muscle atrophy. Again, that's that loss of that cell mass, right? That decreasing of those muscle cells with that rheumatoid cachexia. Increased metabolic rate due to chronic inflammation. And the biggest thing, right, is that we need to focus on patients as an individual. So when you're getting that activity factor, again, right, getting a good history from the patient. So they could be very limited, right? So in how much physical activity they can participate in, activities of daily living they can participate in, or, right, depending on how early it is, right, in the illness or how severe the damage is, then they may not have, right, and they may have a normal activity factor. So again, you need to go through each patient and their patient history as an individual and adjust. So MNT for rheumatoid arthritis. So again, modified consistency and assistance with eating if necessary. So again, if we do have it affecting the joints, the hands, the jaw, etc. Otherwise, right, it's just going to be a normal diet. Elevated protein needs at 1.5 to 2 grams per kilogram. Again, we said that risk of wasting. So the anti-inflammatory diet, which is going to be high in fruits and vegetables and antioxidants naturally. So again, not concentrated from a supplement, doesn't really seem to do much, but a chronic long-term intake of a diet high in fruits and vegetables. Again, looking at our fatty acids, we know we're looking at favoring omega-3s for reducing inflammation and reducing omega-6s. So it's going to be from fish oil, right, as a supplement usually, so to increase that EPA and DHA. We know that folate, right, is going to be at an increased need for taking methotrexate, so in a folate supplement, calcium and vitamin D due to the prednisone, and again, possible benefit for exclusion of red meats, dairy, certain cereals, wheat, gluten, evaluating and testing for any food allergens. And then, so drinking large amounts of tea may increase the risk of RA, that's one study. Whereas other studies didn't show that link, but it's just some interesting, again, we don't know the exact cause, but there's some interesting data out there. And so now we'll move on to gout, also known as gouty arthritis. So this is a disorder of purine metabolism in which abnormally high levels of uric acid accumulate in the blood, resulting in hyperuricemia. So it's an inflammatory disease, results in swelling, redness, heat, pain, and stiffness in the affected joint. Again, right, this is why they also have the word arthritis in common. Again, I know it's sounding a little repetitive, but we're looking at very different causes. Now, the other nickname for gout is the disease of kings. And so this is one of the oldest diseases in medical history, so we actually do have good records based on their physicians and what they recorded as symptoms. So known sufferers of gout include Henry VIII and Alexander the Great. And so gout is more common in men and usually occurs in adult men after the age of 35. So taking a look at this, so hyperuricemia results from an overproduction of uric acid, inadequate elimination by the kidneys, or a combination of both. And so uric acid crystals form in the joints and in soft tissues surrounding the joints. It is considered one of the most painful arthritic conditions. Now, what you have is it's extremely painful, but for short periods of time if treated. So again, basically there's a trade-off for intensity, but again, there's a lot more treatments, and again, it goes away fairly quickly when treated properly. So the prevalence has doubled in the US in the past 30 years. When we take a look at the food sources, that'll make a lot of sense. So risk factors for gout include genetics, being a man, being older, being overweight, drinking too much alcohol, eating foods high in purines, exposure to lead, certain drugs increase your risk, including diuretics, and then the other one is a high fructose intake. So this is actually brand new. So I actually had this, a student brought this up basically in a previous discussion, and so now one of the things we're looking at for that production, right, of that uric acid or that lack of elimination is from high fructose intake. And so other things that we've noticed is that associated with gout, including other comorbidities, is hypertension, diabetes, dyslipidemia, and insulin resistance. So foods that are very high and moderately high in purines. So we have anchovies, sardines, fish roe, gravies, meat extracts, beef kidneys, liver, sweetbreads, which do not contain any kind of bread at all, and nutritional or brewer's yeast. And so moderately high, you've got asparagus, cauliflower, legumes, all your meat categories, your meat soups and broths, mushrooms, oatmeal, spinach, and wheat germ or bran. And so when we take a look at from a historical standpoint, right, the foods that the king would consume, right, is pretty much your very high purine food list, right? So in essence, right, as a display of wealth, you ate a lot of animals. And then even on the right, we still had foods that were fairly high, which was again, be our other meat dishes, meat soups, meat broths. And then even if we were a peasant, right, so looking at our vegetable intake, our oatmeal, our wheat bran, etc. So it's not hard to see why people were consuming so many of these purines. So clinical manifestations, so we have urate deposits, which is those uric acid crystals, which can destroy the joint tissue. And so sodium urates are formed and deposited in the form of tophi in the small joints and surrounding tissues. Now, what's famous for gout, or its most famous indicator, is that it affects the great toe or the big toe, right? It'll be extremely swollen and bright red, but can also affect, right, the instep, ankles, heels, knees, wrists, elbows, and fingers. So symptoms occur rapidly, i.e. you don't follow the diet the night beforehand, you'll wake up the next morning in severe pain, swelling, with shiny red skin around the joint and extreme tenderness. Now, it typically resolves in 5 to 10 days, but does reoccur with flare-ups or exacerbation if you don't follow the diet. So if the patient's compliant with the diet, right, then these flare-ups are very uncommon. But again, this is one of those, right, with the onset being very quickly. If you quote-unquote cheat on the diet the night beforehand, you will know about it the next day. And so here you can see, right, so you see these tophi, these deposited uric acid crystals, and in essence, right, if you actually look at them on an x-ray, it looks like ground up shards of glass are inside the joint, and sure enough, that's what patients say it feels like, is that basically you have ground up glass, right, or these crystals growing, right, inside your soft tissues. And so here's an extreme example. And so this is actually the growth of the crystals. Now this is actually occurring in the ear, but imagine those being inside, right, inside your feet, right, where again, it's basically a mineral deposit or a mineral crystal that's actually damaging your tissues on the inside. So acute attacks may be precipitated by excessive exercise, medications including aspirin, diuretics, nicotinic acid, cyclosporines, levodopa, overconsumption of purine-rich foods, overconsumption of alcohol, and crash dieting, fasting, and a low carbohydrate diet. So the treatment, so we're going to have NSAIDs in the short term and glucocorticoids, right, that infamous prednisone for the swelling. We do have a couple different drugs. So we have colchicine, which is going to help with joint pain, and allopurinol, which is the long-term treatment to actually help inhibit or reduce some of the uric acid production. Now again, our lifestyle factors, so moderate to no alcohol consumption, avoiding purine-rich foods, and maintaining a healthy body weight with no fluctuations, right, in either direction. We don't want you to lose a bunch of weight or gain a bunch of weight and then lose it, right? This yo-yo dieting, right? We want to maintain a pretty even body weight. And so here again, we can see those risky foods. So anchovies, herring, sardines, mushrooms, mussels, organ meats, alcohol, etc. So here we have our purine content. So you have it in basically in lower amounts, medium amounts, and then high amounts. So group C is going to be your highest. And this is again where we saw things like caviar, shellfish. Let's see, you have your meat extracts, things like Marmite, Vegemite, right? So again, things that are coming from that brewer's yeast. In your medium group, you have basically a lot of your animal foods. But you also have your lentils, soybeans, let's see what else is interesting in there. Peanuts, your brassicas, so your cauliflower, broccoli, and for those of you that don't know, in case you see what the corn is, that's protein from mushrooms. And then group A, your lower quantities, is going to be your milled cereals, dairy products, olives, tea, coffee, etc. So again, lifelong avoidance of high purine foods. Again, average diet contains 600 to 1,000 milligrams per day. For someone with gout, we need to limit that to 100 to 150. So looking at the previous slide, basically group C is off limits. And then A and B, right, still have to be limited and paying attention. Encouraging fluids to assist with the excretion of uric acid and minimize the risk of kidney stones. And then dairy products, eggs, vegetable protein, cherries, and coffee appear to have a protective effect. So again, with gout, it may be beneficial for an intake of those foods. All right, so we'll move into Sjogren's syndrome. So again, another autoimmune disease characterized by lymphocytic infiltration of the exocrine glands, particularly the salivary and tear glands. And so this is treated, right, so most commonly with artificial tears. So for dry eyes, artificial tears. For dry mouth, biotin or artificial saliva. Immunosuppressant eye drops or other OTC medications, right, your classic Visine. Approximately 4 million Americans living with Sjogren's. And so again, the big thing is, did you go and get it diagnosed versus people just say, oh, I have bad allergies. Oh, I've had dry eyes my whole life. I just use eye drops. Again, right, so like all autoimmune illnesses, this is going to be on a spectrum of severity. For some patients, it's going to be very severe. And so, of course, they've gone and gotten diagnosed. And others are treating it OTC and don't realize that they actually have an autoimmune disease. So signs and symptoms, right? The classic symptoms are going to be dry eyes and dry mouth, which is xerostomia. So increased thirst, right, because of the dry mouth, burning sensation, right, of the dry oral mucosa, glossitis, cheilitis, chelosis, dysphagia, and an increased risk for severe dental caries or cavities, nocturnal oral discomfort, dysomia, and dysgeusia. So we've got changes in taste and changes in smell, right, because again, a change in our mucous membranes. So the goal is to relieve symptoms and reduce eating discomfort, managing the dry mouth. So this can be achieved with sugar-free gum, rinsing the mouth frequently with water, brushing the teeth more frequently than usual, and using topical fluorides to help protect them. Reducing sugary foods, so again, there's not saliva to rinse the sugar off of the teeth, increasing your risk of cavities. Soft, moist foods, again, things like gravy, and avoiding extreme temperatures, so things that are ice cold and things that are hot like soup, right? We want things to be much more room temperature or tepid. Limiting citrus, spicy foods, and other irritants, although sour flavored candy may help increase saliva production, but again, too much, right, would actually be damaging or painful. So fibromyalgia, so chronic musculoskeletal disorder characterized by widespread muscle pain, joint stiffness, disturbed sleep, fatigue, headache, cognitive and memory problems. The nickname for that you'll also hear it's known as fibrofog. Paresthesias and tender points. So this affects 2 to 4% of the U.S. population, or about 12 million people, with 80 to 90% of cases being female. And so we don't know, and so for the longest time, you may hear that fibromyalgia is quote unquote a fake illness. And so the problem is that it's not, obviously. What it is that our current diagnostic technology can't really pinpoint what's wrong. So it may be associated with traumatic or emotionally stressful events, again, often seen as a comorbidity with other autoimmune disorders. And other risk factors include low levels of serotonin, reduced levels of growth hormone, depression, anxiety, somatoform disorders, and hypochondriasis. And so again, the problem is currently with our current diagnostic technology is that what we don't have is, for example, right, is that definitive testing, which is for lupus, for example, we can test for antibodies. If you have a bacterial infection, I can take a sample of your blood. We know there's something wrong, but we aren't really able to test for it in a definitive way with fibromyalgia. So currently what we do is we have to rule out other causes. So the criteria from the American College of Rheumatology, so pain that's been widespread for at least 3 months, and excessive tenderness or pain with at least 11 of the 18 tender points. And in 2009, new diagnostic criteria based on a combination of the pain and the severity score, fatigue, sleep disturbance, cognitive dysfunction, and other signs and symptoms. So here you can see the tender points, and so in essence, these are extremely sensitive to touch. So again, things that would normally be just normal pressure to you may be extremely painful to a patient that has fibromyalgia. So treatment goals: improve sleep, treating the depression, anxiety, and pain, improving patients' ability to relax. So you're going to see antidepressants and counseling, physical activity, cognitive behavioral therapy, and patient education. From an MNT standpoint, right, we're going to be focused on weight control, avoidance of foods. Again, it's going to be individual based. There is no fibromyalgia diet, but a low sodium, Raw vegan diet has worked in some case studies. Again, nothing definitive at the clinical trial level. Quercetin may play a role as an anti-inflammatory. MSG, again, may be a trigger, may not. So the thing is right, again, because we're having problems pinpointing exactly what's causing it, there's a lack of sound scientific evidence. Other things that are frequently used as treatments, though, include acupuncture, massage therapy, and chiropractic therapy. Again, though, what we're looking for is a very non-specific disease process, and we're not really able to pin down the cause at this time. So chronic fatigue syndrome, I'll let you guess for just a second what the main symptom is, which is going to be chronic fatigue. But in this case, right, this is lasting 6 months or longer. And so this is usually accompanied by low blood pressure, sore throat, joint pains, headaches, post-exertion lethargy, muscle pain, impaired concentration. So this affects 0.007 to 2% of the US population. Again, not fully understood etiology, but treatment includes increasing tolerance to exercise, MNT, appropriate sleep hygiene, antidepressants, and cognitive behavioral therapy. So we'll take a look at scleroderma. And so if you've looked at our previous medical terminology, so you'll know that sclerosing, right, is looking at hardening or stiffening, and derma is of the skin. So here we have chronic systemic sclerosis, or hardening of the skin and visceral organs, characterized by the deposition of fibrous connective tissue. So 4 times more common in women. So it's an autoimmune rheumatic disease with a genetic component for risk. Now we have a secondary syndrome that occurs frequently in this population, which is Raynaud syndrome. So here we have ischemia or coldness in the extremities. And so what will happen is basically the tips of their fingers and toes, right, would go completely white with a loss of feeling due to a lack of blood flow. And so in addition to the fact that you have to treat that, and there's some actual physical manipulations to improve blood flow to the extremities, but right, that loss of sensation, right, can cause a difficulty in preparation and then consumption of meals. Now again, this occurs secondary just also in these patients, but they're not the same thing, and they're not caused by each other. So Raynaud's is also caused by other things. For example, smoking tobacco can actually, in a certain percentage of the population, causes Raynaud syndrome. So signs and symptoms, right? So imagine in addition to your skin building up scar tissue, so imagine every single minor injury you have causes scar tissue, but it's very, very stiff scar tissue that tears very easily. Your organs are also going to become stiff and hard. So this has signs and symptoms, for example, of GERD, nausea, vomiting, diarrhea, constipation, problems swallowing, fecal incontinence, small intestine bacterial overgrowth, joint stiffness and pain, renal dysfunction, hypertension, and pulmonary fibrosis. So your esophagus, right, any injury, right, when you ate that corn chip and you might have scratched yourself on the inside and it was a little painful for a day or so, well, in this patient population, they're actually going to grow scar tissue. If we've ever had any damage to the lungs, again, they're going to grow scar tissue, right? And every time there's scar tissue, the organs get less and less flexible. They're more likely to tear and have further damage. I always think this photo is very annoying in the book, but what this is doing is trying to show trismus, which is the fact that, so because the tissue is so hard and stiff, excuse me, the patient actually can't physically open their mouth any further without tearing their skin. But again, that's one of many, many other issues that can happen. So, but in this case, right, is that the mouth cannot actually open any further. So treatment, again, aimed at relieving symptoms and limiting damage. So there's no current treatment to correct this overproduction of this collagen, this development of scar tissue. So our focus is on fluids, moist foods, sugar-free gum, and saliva substitutes. If the patient has GERD, so again, due to damage to the GI tract, and so that stiffening of that tissue, again, it's our standard treatment of small, frequent meals, avoiding late-night eating, avoiding alcohol, caffeine, spicy, or high-fat foods. And so we'll talk about systemic lupus erythematosus, also known as lupus. So this is a chronic inflammatory disease affecting practically every organ system, especially the musculoskeletal system. Now, it may mimic other diseases at first, so it's difficult to diagnose. It is another major autoimmune disease. And most frequently, so renal function is going to be affected, causing excessive excretion of protein and a form of renal failure. So again, everything that we saw in that renal failure from the renal chapter, right, applies to this patient population. So 90% of cases are women of childbearing age, and approximately 500,000 people in the US currently with lupus. So medical diagnosis, right, so this is based on the presence of autoantibodies and clinical features. So again, unlike fibromyalgia, we can actually do a test and then determine if the patient has lupus. So common early symptoms include pain and arthritis in multiple joints, with fatigue, fever, and muscle aches. And then again, like autoimmune diseases, right, so we have chronic acute flare-ups followed by periods of remission where it either may appear to be absent or much less severe symptoms. And so here we can see, so on the right you have common side effects, and on the left you have what lupus is known for. So again, going back to our medical terminology, or you want to go back to Latin, so if we're looking at lupus, right, we're looking at wolf. And so what you have is what's now known. So previously they would have called this, right, basically being like a wolf mark. So if you look at a dog or a wolf's muzzle, you can see that, right, the muzzle's dark, and then they usually have gray feathering as it goes under the eyes. But in modern medical practice, right, you're going to see this referred to as a butterfly rash. So you can see under the face, right, it makes a very distinctive pattern similar to a moth or butterfly. But in the old days, they would have said it looked wolf-like. And so there is no cure for lupus, just as there currently isn't a cure for any autoimmune diseases. So we do have the pharmacological management during acute flare-ups. So this is NSAIDs for the pain, immunosuppressants to calm the immune system down with corticosteroids. And then, so looking at the butterfly rash you saw on the previous slide. So this is kind of a weird one, but we actually have anti-malarials, which will actually clear up the skin lesions. So that's Plaquenil. But again, it clears up the lesions. It makes the skin look a lot better, but it's not actually curing the lupus. Now we've talked about this, we've talked a lot about autoimmune diseases, and so this is not the only case, but we've talked about autoimmune diseases, and then also looking at transplants. You're going to see this is very common. So this is what's known as moon face. And so you can see, so this is caused by a chronic high intake of prednisone, in which case you're going to have, right, so that fluid retention, and you're going to see, right, the big cheeks, where again, this is not actually cheekbones. This is actually caused by fluid retention in tissue, right, and this is from a long-term high intake of prednisone. So looking at lupus, so limited research in humans. Again, there is no lupus diet. There are possible triggers, but these are going to be identified in each individual. And so things that we've seen, so a restriction of energy, protein, and fat reduces the severity in mice and prolongs lifespan. Again, to see though how this works in humans, it's a little more complicated to make that jump. We want to take a look at protein, fluid, and sodium intake, so especially because we know there's a form of renal failure, so keeping an eye on renal function long term in this patient population. Again, what do you know? Anti-inflammatories and omega-3s seem to improve lupus. And again, it's the same standard drug-nutrient interactions for long-term corticosteroid use. All right, so let's take a look at some practice questions. So steroids, which are often used to treat rheumatic diseases, increase the risk of blank. So we look at our answer choices when we said this. So this is standard. So out of these available answer choices, it's going to be answer choice C, osteoporosis. So again, we know that there's also the concern. So we're going to take a look at increased appetite and weight gain, not weight loss. We know that there's sodium retention, and sodium retention and fluid retention. So again, causing blood pressure issues. And again, then we know, taking a look at our risk of osteoporosis, vitamin D, and bone health. So out of these possible answer choices, the best answer is answer choice C, osteoporosis. Number 2, the most important aspect of medical nutrition therapy for osteoarthritis. So for osteoarthritis is going to be answer choice A, achieving and maintaining a healthy weight. So again, so for osteoarthritis, remember your knees are in essence shock absorbers. So again, we said even just a 10 kilogram weight loss, a 5 kilogram weight loss, so about 12 pounds, reduced our risk for osteoarthritis. In patients with rheumatoid arthritis, inflammation may cause blank. And so we said that chronic inflammation, right, is going to increase metabolic rate. That is answer choice D, increase metabolic rate. Remember, our concern is a form of cachexia, right, or wasting away. So again, we're going to have a loss of muscle mass, and we're going to have a high caloric burn. So it's answer choice D, an increase in metabolic rate. Patients with fibromyalgia should be advised to do blank. And so this is answer choice B, eat a diet high in fruits and vegetables. So again, we said that supplemental antioxidants were not beneficial, but a chronic long-term intake of diets high in fruits and vegetables does appear to be beneficial. And during the Zoom session, right, we will probably discuss nightshades and this patient population. And lastly, patients with gout should be advised to do blank. And so that is actually answer choice D, all of the above. So they should avoid alcoholic beverages, consume adequate fluid, and avoid meat and seafood, so specifically shellfish, but really all seafood. And again, we said we wanted to moderate alcohol consumption, but if we could avoid it, that would be ideal, and with plenty of fluid intake. So that is answer choice D, all of the above. All right, so this lecture will be posted, so you'll be able to then post your questions for our Zoom session. Otherwise, continue to stay safe, study hard, and I will see you all on Zoom.